Welcome back to the deep dive. We are doing something a little different today. Usually we talk about tools that fix things, antibiotics that hunt down bacteria, or, statins that scrub cholesterol.
Very clean mechanisms for the most part.
Right, very clean. But today we are wading into waters that are both incredibly promising and, frankly, they terrified me when I was reading through the source material. We are talking about the most effective tool medicine has ever found for relieving human suffering and simultaneously one of the most destructive forces in modern biology.
It really is the ultimate paradox, isn't it?
Yeah.
It is the classic pharmakon, that's the ancient Greek word that means both remedy and poison, depending entirely on the dose, the context, and the intent.
And today we are dissecting opioids.
Opioids.
It's a word that's in the news constantly, usually for tragic reasons. But today, our mission isn't to rehash the headlines or get into the sociology of the crisis. We are going to the source.
To the molecules.
We are breaking down the actual mechanism of how these drugs work. How do they actually interact with the human machine? Because reading through the chapters you sent over, I realized my mental model of pain relief was completely wrong.
How so? What was the misconception you had?
Well, I thought it was just numbing, like putting ice on a bruise or injecting lidocaine at the dentist. You freeze the nerve, the signal stops, end of story.
Simple circuit breaker.
Exactly. But opioids are doing something much more profound. They seem to be altering how the brain interprets reality itself. They change the meaning of the signal, not just the volume.
That is a very poetic but scientifically accurate way to put it. And to understand that nuance, we are synthesizing 3 heavy hitters from the pharmacological canon today.
Okay.
We have Chapter 20 from Goodman and Gilman's The Pharmacological Basis of Therapeutics, which is essentially the molecular engine room of the topic. It's the how.
The deep physics of it.
Right. And we're pairing that with Chapters 31 and 36 from Katzung's Basic and Clinical Pharmacology.
And Katzung is more the clinical map, right? The user's manual.
Exactly. Katzung gives us the protocols, how these drugs are actually used and misused in a hospital setting. Goodman and Gilman gives us the deep molecular reasoning. So our mission today is to fuse them.
So we've got the engine room and the map, that's our scaffold. But before we dive in, I have to give the standard disclaimer because this is high stakes material.
Absolutely.
This deep dive is an interpretive synthesis. We are building a conceptual framework to help you, the listener, understand the material. This is not medical advice, and it is certainly not a substitute for the textbooks.
Please, read the chapters. Goodman and Gilman Chapter 20 and Katzung Chapters 31 and 36. You cannot treat patients based on a podcast conversation alone. This discussion is designed to act as a scaffold so that when you do read the text, the concepts stick.
Okay, let's orient ourselves. What is our roadmap for this session? If we succeed, what are the big aha moments the listener walks away with?
We have 5 main stops on this journey. First, we need to understand pain as a network. It's not just a telephone wire sending a signal, it's an emotional experience. We're going to see how opioids disconnect suffering from sensation.
Which is a mind-bending concept on its own, that you can have pain without suffering. It sounds like a contradiction.
It is. Second, we're going to look at the receptor trinity, the mu, kappa, and delta systems. If you want to understand why morphine stops pain but also stops your gut from moving, you have to understand these receptors.
Mu, kappa, delta. Got it.
Third is the mechanics of silence. We're going to zoom all the way into the neuron itself. How does a drug actually stop a nerve from firing? Spoiler alert. It involves moving calcium out and potassium in.
I want to spend some real time there because the ion channel mechanics are usually where I get lost, but the text made it seem pretty logical once you visualize it.
We will absolutely break it down so you can see it. Fourth, we have to talk about the adaptation trap. This is the biology of tolerance and dependence. And specifically, we need to understand something called differential tolerance, which is usually the reason people die from overdoses.
That part was chilling. The idea that your body gets used to different effects at different speeds. It's like a ticking clock you can't see.
It is the silent killer.
And finally, we will wrap up with the clinical strategy. We'll look at the pain ladder and how we can use other drugs, like NSAIDs, that's from Katzung Chapter 36, to treat the patient without relying solely on the heavy artillery of opioids.
All right. That is a massive agenda. Let's jump right into Section 1, the problem. What is pain? Because Goodman and Gilman makes a really interesting distinction right off the bat. They talk about acute nociception versus tissue injury.
Right. So let's establish the baseline. We need to distinguish between the signal and the damage. Imagine you pick up a hot coffee cup. It's too hot. You drop it immediately.
Instantly. Without thinking.
Without thinking. That is Acute nociception. Nociception, meaning the reception of noxious stimuli, like a harmful signal.
Exactly. It's a high-threshold signal sent by specific nerve fibers, A delta and C fibers, straight to the spinal cord and up to the brain. It's a warning system. Drop the cup. The tissue isn't necessarily damaged yet. The system is just saying, don't do that.
Okay. That's useful pain. That saves my hand from burning off. That's the check engine light flashing.
Exactly.
Yeah.
But now imagine you actually burned your hand. The cup is gone, but the pain is still there. It's throbbing. It's red. It hurts to touch.
Right.
That's inflammatory pain or tissue injury pain. The area has become what pharmacology calls an inflammatory soup.
A soup.
A soup of chemicals, prostaglandins, bradykinin, cytokines. These chemicals don't necessarily cause a new pain signal, but they sensitize the nerves that are already there. They make the nerves louder. They lower the threshold for firing.
So the alarm is stuck in the on position because the damage is real. The body is guarding the injury. It's telling you, don't touch this, let it heal.
Precisely. Now, here is where Goodman and Gilman provides the critical framework for understanding opioids. They distinguish between the sensory discriminative component and the affective motivational component of pain.
I highlighted this part because it feels like the philosophical core of the issue. Sensory discriminative, that sounds like the raw data,
Yeah.
what and where.
Yes. Think of it as the GPS coordinates and the intensity meter. I have a sharp pain in my right index finger, and it is a 7 out of 10. That is sensory data. It travels up specific pathways like the spinal thalamic tract and goes to the somatosensory cortex.
The part of the brain that's like a map of the body.
The map, exactly. It's just information regarding location and intensity.
But pain isn't just data. It's awful. It has a quality of suffering to it.
Right. That's the affective motivational component. That is the suffering. That is the, I can't stand this, make it stop, I am panicking response. That signal goes to different parts of the brain, the limbic system, the amygdala, the anterior cingulate cortex. This is the emotional processing of the pain.
So pain isn't just ouch. It's ouch plus I hate this.
Correct. And this is where opioids are special. Because reading the text, did you notice how they described the patient's reaction after getting morphine?
Yeah, it was fascinating. It said that patients on morphine will often say something that sounds contradictory. They say, I can still feel the pain, but it doesn't bother me anymore.
Which sounds insane to a healthy person. How can pain not bother you? That's the definition of pain. The bothering is the whole point.
Exactly. It implies that the bothering part is a separate circuit. Opioids sever the emotional attachment to the signal. They cut the wire between the sensory cortex and the limbic system, metaphorically speaking.
Precisely. They turn down the volume knob on the sensory parts, that's the analgesia, but they also disconnect the panic alarm in the limbic system, that's the affective blunting. And clinically, that is incredibly powerful. If you have a patient with a shattered femur, you want to stop the pain, but you also want to stop the terror.
But this is also where the danger creeps in, right? Because that relief from suffering is very close to euphoria. It's the same circuit.
It's the same circuit. If you remove all negative emotion, you leave a vacuum that can be filled with a rush of well-being. And that is the trap we'll talk about later.
Okay, so we have these two components of pain. Now, the texts also differentiate between types of pain states. We have the hot coffee cup nociceptive pain. But what about when the wiring itself is broken?
That's neuropathic pain. And this is a really important distinction clinically. This is nerve injury. Think diabetic neuropathy, where the nerves in the feet are dying.
Or phantom limb pain after an amputation.
Phantom limb pain, shingles, spinal cord injuries. In these cases, the nerve itself is damaged and starts misfiring. It's sending pain signals even when there's no stimulus. Goodman and Gilman notes that this type of pain responds less well to opioids.
That's a crucial expectation to set for patients and clinicians. It's not a cure-all. If the wire is cut and sparking, damping the signal at the receiver in the brain might not work as well.
Right. In fact, other drugs, like certain antidepressants or anticonvulsants, often work better for neuropathic pain. It's a different pathology.
And there's one more paradox we have to mention before we move on to the mechanism. This idea of hyperalgesia.
Yeah, this was weird, right? The idea that pain can actually make you more sensitive to pain?
It sounds completely backward.
It is, but injury can cause peripheral sensitization. We talked about the inflammatory soup making nerves touchy. But it can also cause central sensitization. The spinal cord itself turns up the volume. The neurons in the dorsal horn become hyperexcitable.
So the amplifier gets cranked to 11.
Exactly. So a touch that shouldn't hurt, like a bed sheet on a burned victim's skin, suddenly feels excruciating. That's called allodynia. feeling pain from a non-painful stimulus.
So the system is learning to be in pain. It's creating a memory of pain that amplifies the current signal.
In a way, yes. It's a form of neuroplasticity, and as we'll see later, one of the cruelest ironies is that opioids themselves can sometimes inadvertently feed into this system, creating a vicious cycle of opioid-induced hyperalgesia.
Wow. Okay, so we know the enemy. Pain. It's sensory, it's emotional, and it can be amplified by the body. Now let's talk about the weapon we use to fight it. Let's move to section 2. The mechanism.
Finding the keyhole.
I love the history here. Goodman and Gilman points out that humanity used opium for centuries, millennia, really, without having a clue how it worked. It was just this magical poppy juice that stopped pain and made you feel good.
It wasn't until the 1970s, which is incredibly recent in the history of medicine, that we figured it out. A few key researchers, Goldstein, Pert, and Snyder, they were working independently, but all arrived at the same place. They discovered stereoselective binding sites in the brain.
Okay, stereoselective, that means it's specific to the 3D shape of the molecule, right? Like a key.
Exactly. A left-handed glove doesn't fit a right hand. They found that only the left-handed version of morphine, the active isomer, would bind. The right-handed version wouldn't.
Which means it's not just some random chemical reaction, there's a lock.
There's a specific evolved protein lock in the human brain that is perfectly shaped to fit morphine.
Which immediately implies that the human body must have its own key that looks like morphine. We didn't evolve to smoke poppies. The poppy just happens to produce a molecule that fits our pre-existing lock.
Exactly. That was the aha moment. Why would we have a receptor for a plant? We wouldn't. We must have our own internal pharmacy. And that led to the discovery of the endogenous opioids, endorphins, enkephalins, and dynorphins.
So we have the keys, the endorphins, and we have the locks, the receptors. Let's meet the receptors, the receptor trinity, as we called it in the roadmap.
Right. We have mu, kappa, and delta. These are the three main families.
Let's start with mu. The text calls this the star of the show. Why is it the most important?
The mu receptor, or MOR for mu opioid receptor, is the most important one for clinical analgesia. When you give morphine, fentanyl, methadone, oxycodone, they're primarily hunting for the mu receptor.
And what does mu do when it's activated?
It does the heavy lifting. It provides supraspinal and spinal analgesia, so pain relief in the brain and the spinal cord. It's responsible for that profound sense of well-being, the euphoria.
But there's always a but.
But, and this is critical, it's also responsible for the major downsides. Respiratory depression, which is what kills people in an overdose. It's also responsible for the physical dependence, and it's the main driver of the constipation.
So the good and the bad are packaged in the same receptor. You can't separate the pain relief from the respiratory risk at the receptor level.
Largely, yes. Nature didn't design the mu receptor for fentanyl. It designed it for endorphins, which are released in very specific situations and are regulated strictly by the body. When we flood the system with exogenous drugs, we trigger everything at once.
It's like using a fire hose when you only needed a squirt gun.
Very good analogy.
Okay, then we have the complicated cousin, kappa.
Kappa is...
Difficult.
Kappa receptors, or KOR, also provide pain relief, particularly at the spinal level. But activation of kappa receptors is associated with dysphoria.
Dysphoria. So the exact opposite of euphoria.
Yes. Patients feel terrible, anxious, weird, a sense of depersonalization. At high doses, you can get psychotomimetic effects hallucinations. This is why we don't use pure kappa agonists for pain relief. The physical pain might stop, but the mental state becomes unbearable.
Fascinating. So nature separated the feel-good pain relief, mu, from the feel-bad pain relief, kappa.
It makes sense from an evolutionary standpoint. Sometimes you need pain relief to run away from a tiger. That's stress-induced analgesia. But you don't want to be high and relaxed. You want to be alert and maybe a bit anxious. That seems to involve the kappa system, which is mediated by the body's own dynorphins.
And what about the third one, delta?
Delta, or DOR, is the quiet one, at least clinically. It's involved in analgesia and modulating hormones. It seems to work with the mu system. There's a lot of research into delta, trying to find a drug that hits it without the mu's side effects, but clinically, we don't have many drugs that target only delta. So for our purposes, mu is the protagonist.
Mu is the main character of this story. Okay, let's zoom in. We're at the mu receptor. A molecule of morphine floats by and locks in. What happens? I want the deep dive into the cell biology here, because this is where the rubber meets the road.
This is pure Goodman and Gilman. Opioid receptors are G-protein coupled receptors, or GPCRs. Specifically, they're coupled to inhibitory G proteins called G or GO.
G stands for inhibitory.
Exactly. When the drug binds to the receptor on the outside of the neuron, it activates this G protein on the inside. This triggers a cascade that does two main things to silence the neuron. One happens at the sending end, the presynaptic terminal, and one happens at the receiving end, the postsynaptic membrane.
Okay, let's take the sending end first, the presynaptic terminal.
Right, so you have a nerve that's trying to send a pain signal. To do that, it needs to release neurotransmitters like glutamate or substance P into the synapse.
It needs to shout the pain message to the next neuron.
To shout, it needs calcium. When a nerve fires, voltage-gated calcium channels open and calcium ions, Ca2+, rush into the cell. Calcium is the trigger that tells the vesicles full of neurotransmitters to fuse with the membrane and release their contents.
So calcium is the finger on the trigger. It comes in, pushes the send button, and the neurotransmitter flies out across the gap.
Correct. But when the opioid binds to the presynaptic receptor, the G protein becomes active, and it directly closes voltage-gating calcium Ca2+ channels.
Calcium channels close, so the trigger is jammed, the finger can't pull it.
No trigger. If calcium can't get in, the neuron cannot release its payload. The vesicle full of pain signals just sits there, ready to go, but it never gets the signal.
So the shout of pain is strangled in the throat of the neuron. It never even leaves the cell.
Exactly. The signal is silenced at the source. It's a presynaptic inhibition.
And what's number 2? The postsynaptic end, the receiver.
Number 2 happens on the neuron that's listening for the signal. The opioid binds to a mu receptor on this postsynaptic neuron, and the G protein here does something different. It causes G protein-coupled inwardly rectifying potassium K+ channels to open. We call them GIRKs.
Okay, that's a mouthful. Let's break it down. Potassium channels open. Now, potassium is concentrated inside the cell, right?
Correct. There's way more potassium inside the cell than outside. So when you open a door for it, it rushes out down its concentration gradient.
Okay, so a positive charge, the potassium ion, is leaving the cell.
Yes. If positive charge leaves, the inside of the cell becomes more negative relative to the outside. We call this hyperpolarization.
And a hyperpolarized neuron is hard to wake up.
It's basically in a coma. To fire, a neuron needs to reach a certain positive threshold. If you make it more negative to start with, you need a much bigger signal to get it to fire. So even if a faint pain signal did get across the gap, the receiving neuron is asleep and won't pass it on.
So it's a double whammy. On the sending side, you jam the trigger by blocking calcium. On the receiving side, you sedate the listener by letting potassium out.
Perfectly put. That is the cellular mechanism of silence.
Now, there was one more mechanism mentioned, something about disinhibition in the brainstem. This sounded like a double negative, like you're inhibiting an inhibitor.
It is. This is a systems-level effect, and it's really elegant. This happens in an area of the brainstem called the periaqueductal gray, or PAG. This is a major control center for descending pain control.
Descending, so the brain's sending signals down to the spine to control pain.
Yes. Your brain can actively talk to your spinal cord and say, ignore that signal. It's a top-down system. But normally, this descending pain relief pathway is kept quiet. It's held in check by brake neurons that release GABA.
And GABA is the main inhibitory neurotransmitter in the brain. It's the brakes.
It's the brakes. So the body keeps its own powerful pain relief system clamped down with GABAergic brakes. Opioid receptors are located on these GABA neurons. And when opioids bind, they shut them off, using the same calcium-potassium mechanism we just discussed.
So they turn off the off switch, they take the foot off the brake.
Exactly. They inhibit the inhibitor. By taking the foot off the brake, the pain-blocking pathways that originate in the PAG are now free to fire. They send signals down to the spinal cord, releasing norepinephrine and serotonin, which then inhibit the pain signals coming in from the periphery.
That is incredibly elegant. It's not just blocking pain, it's actively turning on the body's own anti-pain system. It's hacking the system's own checks and balances.
It is, and it explains why these drugs are so potent. They work at the site of injury in the periphery, they work in the spinal cord's dorsal horn, and they work in these brainstem control centers. It's a full-spectrum assault on the experience of pain.
Okay, so we know how the engine works. Now let's look at the cars. Section 3, clinical integration. We're moving into ketone territory now, the drugs themselves.
Right. And Katzum organizes them nicely. We can start with the full agonists, the heavy hitters.
Starting with the prototype, morphine.
Morphine is the yardstick. It's the classic opioid derived from the opium poppy. Everything else is measured against it. We literally use a conversion factor called morphine milligram equivalence, or MME, to compare the potency of different opioids. It has a high affinity for mu receptors, It works.
But it has limitations. The text mentions it releases histamine.
Yes, which can cause itching, flushing, and sometimes a drop in blood pressure. And there was a really important note about its active metabolites, meaning the body breaks it down, but the trash is still active.
Exactly. When the liver metabolizes morphine, it creates morphine 6-glucuronide and morphine 3-glucuronide. The 3 metabolite can cause neuroexcitatory effects, but the 6-foot metabolite, M6G, is actually a more potent analgesic than morphine itself.
So the breakdown product is stronger than the original drug?
In some ways, yes. And both morphine and M6G are cleared by the kidneys. So what happens if your patient has renal failure? They can't clear it. It builds up.
It builds up. So you can overdose a kidney patient on a completely normal dose of morphine just because they can't clear the active trash. It accumulates and they stop breathing.
That's a huge clinical pearl. And then we have fentanyl. This is the one that seems to be everywhere now. Katzum mentions it's 100 times more potent than morphine and highly lipid soluble. Why is that the key differentiator?
Lipid solubility means it dissolves in fat. The brain is basically a lump of fat protected by a blood-brain barrier, which is also fatty. Because fentanyl loves fat, it crosses the blood-brain barrier incredibly fast. It hits hard and fast. Morphine is slower, it's more water-soluble, so it has to trudge through to get to the receptors.
So fentanyl is the speedboat, morphine is the barge.
Yes, and that speed is what makes it so potent and so dangerous. Its rapid onset is useful in anesthesia or for severe acute pain, but it's also what makes it so addictive. And that speed leads to a specific risk that Katzum mentions, truncal rigidity.
The wooden chest syndrome. I've heard of this.
It's rare but terrifying. If you push fentanyl too fast through an IV, the muscles of the chest wall and abdomen can seize up. They become rock hard. You literally cannot ventilate the patient. You can't squeeze the bag valve mask. You can't make their chest rise.
That sounds like a nightmare. You're trying to help them breathe because the opioid is depressing their respiration, but the door to their lungs is locked from the outside.
And the only way to unlock it is to give a neuromuscular blocker, a paralytic, or give naloxone, which reverses the pain relief you're trying to achieve. It's an emergency you never want to see.
Okay, moving on to methadone. I always associate methadone with rehab clinics for opioid use disorder, but the text says it's used for chronic pain too.
Methadone is unique. It's a full mu agonist like the others, but it has a very long and very unpredictable half-life. It can be anywhere from 15 to 60 hours.
That's a huge range.
It's massive. And mechanistically, it does something the others don't. As well as being a mu agonist, it also blocks NMDA receptors.
NMDA, that's a glutamate receptor, right? The main excitatory one.
Yes. And remember we said earlier that central sensitization, the spinal cord getting louder, the allodynia involves glutamate and NMDA receptors. Well, because methadone blocks that NMDA receptor, it can be particularly good for neuropathic pain or difficult to treat pain states where the system is wound up.
So it's an opioid plus a little bit of a system reset.
In a way, yes, but that long half-life makes it so dangerous. You take a pill, you might not feel much. So you take another. 12 hours later, the first one is peaking and the second one is peaking. We call it stacking. It requires expert dosing and very slow titration.
Dangerous. Now, what about buprenorphine? This is listed as a partial agonist. What does that mean?
This is a crucial concept. Buprenorphine binds to the new receptor very tightly. It has a very high affinity, even tighter than morphine, tighter than heroin. But it doesn't turn the key all the way. It only activates the receptor partially. It has lower intrinsic activity.
You get a ceiling effect.
Exactly. You get some pain relief and some euphoria, but you reach a point where taking more drug doesn't give you more effect. This makes it much safer regarding respiratory depression. It's harder to stop breathing on buprenorphine than on fentanyl because the receptor simply won't turn on enough to shut down the brainstem completely.
That makes it a great tool for treating opioid addiction. But there's a trap, right? If you give it to someone who is actively high on heroin.
Disaster. Absolute disaster. Because buprenorphine binds so tightly, it will kick the heroin, which is a full agonist, off the receptor. It bullies its way in and takes over.
Okay.
But because buprenorphine is only a partial agonist, the total effect on the system drops, plummeting down.
So the patient goes from 100% receptor activation from the heroin to maybe 40% activation from the buprenorphine in seconds.
And that sudden drop is withdrawal. We call it precipitated withdrawal.
You rip the warm blanket off and replace it with a thin sheet in the middle of a blizzard.
And the patient goes from high to the worst flu of their life in seconds. Agitation, sweating, vomiting, diarrhea. They will not forgive you for that. You have to wait until they are already in mild withdrawal before you start it.
Yikes. Finally, in this section, the rescue squad, the antagonists. Naloxone.
Naloxone is the antidote. It's a pure antagonist. It has a high affinity for the mu receptor, but zero efficacy. It binds to the receptor, but does nothing. It just sits there and blocks it. If there's an opioid there, like fentanyl, it shoves it out of the way.
We see this in movies all the time. The overdose patient wakes up gasping.
It is miraculous to witness. A person can be blue, not breathing, and within a minute of an injection, they're awake and talking. But Cadsong has a critical warning about the duration of action. Naloxone is very short-acting. It wears off in 30 to 60 minutes.
But something like methadone or even heroin can last for hours.
Exactly. So imagine this scenario. A patient overdoses on methadone. Paramedics arrive, give naloxone. The patient wakes up. They feel okay, maybe a little sick from the withdrawal, but they're breathing. They get to the ER and sign out against medical advice. They walk to the parking lot.
And then?
An hour later, the naloxone falls off the receptor. But the methadone is still floating around in their blood. It latches back onto the now empty receptors. The patient goes back into a coma and dies in their car.
Oh, wow.
That is called re-narcotization.
That is a terrifying word.
Yeah.
Re-narcotization.
So you have to watch them until the opioid is actually gone, not just until they wake up from the antidote.
Yes. Observation for several hours is non-negotiable.
There was one other antagonist mentioned, methyl naltrexone.
Yeah.
This one has a methyl group that makes it so it doesn't cross the blood-brain barrier. Right. It's a peripherally acting antagonist. It stays in the body, not the brain. So if a cancer patient on chronic high-dose opioids has terrible constipation, which is a peripheral effect in the gut, you can give methyl naltrexone. It blocks the opioid receptors in the gut, relieving the constipation, but it can't get into the brain, so it doesn't reverse the pain relief.
That is clever pharmacology, solving the side effect without ruining the therapy.
Precision medicine at its finest.
Okay, this leads us perfectly into section 4, the shadow side. We've touched on it, but we need to define these terms clearly. Tolerance, dependence, and addiction. Because in the media, and even sometimes in medicine, they are used interchangeably, but Goodman and Gilman is very strict about the definitions.
They are biologically distinct phenomena, and mixing them up leads to bad patient care and a lot of stigma.
Let's start with tolerance.
Tolerance is a pharmacological concept. It's when you need to increase the dose to get the same effect. Over time, the body adapts. The biology is interesting. With repeated stimulation, the receptor can become uncoupled from its G protein. The phone rings, but no one answers.
The G protein stops listening.
Right. Another mechanism is receptor internalization. The cell literally pulls the receptor inside, away from the surface, so the drug can't find it.
So the cell stops answering the phone by taking it off the hook.
Basically.
Yeah.
Interestingly, Goodman and Gilman notes that morphine is actually bad at causing internalization of the mu receptor. It leaves the receptor on the surface, but desensitized. Other drugs, like fentanyl, are better at causing it to recycle. But the end result is the same. You need more drug to get the same result.
Then there is dependence. This is an addiction.
Not at all. Dependence is a physiological state. It just means the body has adapted to the drug being present and has created a new homeostasis. If you stop the drug abruptly, the system, which has been pushed in one direction, swings violently back in the opposite direction.
Withdrawal.
Yes. And think about what opioids do. Constipation, pinpoint pupils, sedation, analgesia. So withdrawal is the mirror image. Diarrhea, dilated pupils, agitation, anxiety, and profound pain. It's like the worst flu of your lifetime sin.
And finally, addiction, the behavioral component.
Addiction is not about the receptor. It's about the behavior. The formal definition is compulsive use despite harm. It involves craving, loss of control, and continued use, even when it's destroying your life, your family, your job.
So, and this is the key point, a cancer patient on high-dose morphine for months is certainly dependent. They will get sick if they stop suddenly, and they are certainly tolerant. They need high doses for their pain, but they are not necessarily addicted.
Correct. They aren't robbing pharmacies or crushing pills to get high. They are treating a symptom. That distinction is vital for clinicians. We shouldn't label a pain patient as an addict just because they have physical dependence.
Absolutely. However, now we have to talk about differential tolerance. This is, in my opinion, the most dangerous concept in this entire deep dive.
This is the adaptation trap we mentioned in the intro. It's the silent killer.
It's the idea that tolerance develops at different rates for different effects.
Yes. Break that down for us.
Okay, so tolerance to euphoria, the high develops rapidly. An addicted user needs more and more drug just to feel good or even just to feel normal.
Right. They're chasing that initial high, which they can never get back.
Tolerance to analgesia develops moderately. A pain patient might need their dose increased over time. But, and this is TAP, tolerance to respiratory depression develops, but it develops much more slowly than tolerance to euphoria.
I see where this is going.
So the user increases the dose to chase the high. They are tolerant to the euphoric effects of, say, 100 milligrams of oxycodone, but their brainstem is not yet tolerant to the respiratory depressant effects of 100 milligrams. They overshoot the safety margin without realizing it.
They take a dose that makes them feel normal or high, but that same dose is enough to stop their breathing because the brainstem haven't caught up with the tolerance that's developed in the reward pathways.
Exactly. The gap between the high dose and the lethal dose narrows and narrows until it disappears. And there are some effects, like constipation and meiosis, the pinpoint pupils, that develop almost no tolerance.
So a chronic user will always be constipated and always have small pupils, no matter how tolerant they are to the other effects.
Correct. Which is why pupil size is such a good diagnostic tool for an overdose, even in a heavy user. If they are comatose and have huge dilated pupils, it's probably not an opioid overdose unless they took something else too. If they are comatose with pupils the size of a pinhead, think opioids.
That is a crucial nugget for anyone working in emergency medicine.
It is.
Let's move to Section 5. Adverse effects as mechanistic consequences. Goodman and Gilman frames this beautifully. These aren't random side effects. They are receptor effects happening in the wrong place.
Right. They are predictable outcomes of activating the mu receptor throughout the body.
We've mentioned respiratory depression. The text explains the mechanism is about CO2 sensitivity.
Right. This is subtle, but so important. Normally, if you hold your breath, carbon dioxide builds up in your blood. Your brainstem has chemoreceptors that taste that CO2. They panic, and they force you to gasp for air. It's the air hunger. It's terrifying and impossible to ignore.
Opioids dull that sensor.
Yes. They reduce the brainstem's sensitivity to rising CO2. The CO2 level climbs, but the brainstem says, it's fine. The body literally forgets to breathe.
And this is made worse by sleep.
Exponentially worse. Your respiratory drive naturally drops when you sleep. If you combine opioids, sleep, and maybe a glass of wine or a Xanax, a benzodiazepine, which also depress respiration through a different mechanism.
You create a perfect storm of respiratory depression. The patient simply stops breathing in their sleep. They don't gasp. They don't struggle. They just fade out.
Terrifying. Now, the bowel problem. We mentioned no tolerance develops here. What's the mechanism?
The gut has a dense network of opioid receptors in what's called the enteric nervous system. It's like a second brain. Opioids act on mu receptors there, and they do two things. They increase tone, but stop propulsion.
Translation.
The gut clamps down tight. That's increased tone. But it stops the wave-like motion, peristalsis, that moves food forward. The food just sits there in the colon. The water gets sucked out of it. It turns into concrete.
Graphic, but crystal clear. And the clinical pearl from Katsung is unavoidable.
You must prescribe a bowel regimen with chronic opioids. Senna, stool softeners, laxatives. You cannot just hope for the best. The opioid-induced constipation will not go away on its own. It effectively paralyzes the gut.
And lastly in this section, opioid-induced hyperalgesia again. This paradox.
It's a cruel irony. In some patients, particularly with long-term high-dose use, the opioids can actually start to make pain worse. The mechanisms are complex, but they may involve upregulation of spinal dynorphin or activating inflammatory signaling pathways. The patient comes to you saying, "The pain is worse, I need more meds."
But if you give more meds, you feed the fire.
Correct. The treatment is actually to lower the dose or rotate to a different opioid like methadone, which has that NMDA action. But that is a very hard sell to a patient who is in agony.
I can imagine. You're hurting, so I'm going to reduce your painkiller. That requires a lot of trust and a lot of explanation of the underlying pharmacology.
And a lot of understanding of the mechanism. If you don't understand hyperalgesia, you'll just keep increasing the dose until the patient is comatose but somehow still in pain.
This brings us to the solution, or at least the strategy for management. Section 6, the pain ladder and multimodal strategy. This is where we bring in Katsung Chapter 76 on NSAIDs.
The concept here is sparing. We want to spare the patient the risks of high-dose opioids. How do we do that? We attack the pain network at different nodes.
We don't just rely on the central mute button, the opioids. We go to the source of the inflammation. Enter NSAIDs, ibuprofen, naproxen, celecoxib.
Right. Opioids work in the CNS, the central nervous system. NSAIDs work primarily in the periphery, at the site of the injury.
Let's do a quick mechanism refresher from that chapter, COX inhibition.
So when you have tissue injury, the damaged cell walls release a fatty acid called arachidonic acid. Then enzymes called cyclooxygenase, or COX, turn that acid into prostaglandins.
And prostaglandins are the sensitizers. They don't cause pain themselves, but they make the nerve endings raw and angry. They pour gasoline on the fire.
Exactly. So NSAIDs work by blocking the KOX enzyme. They stop the factory that makes the prostaglandins. If you stop the prostaglandins, the nerve ending isn't as loud.
So if the nerve isn't screaming as loud at the site of transduction, the spinal cord doesn't get as overwhelmed and you need less opioid to manage the signal in the brain at the site of perception.
Synergy. 1 + 1 = 3. Better pain control with a lower dose of opioids, which means fewer side effects.
Ketsung Chapter 36 also mentions the different types of NSAIDs. We have the non-selective ones like ibuprofen, which block both KOX1 and KOX2.
And KOX1 is the housekeeping enzyme. It protects your stomach lining and helps your platelets stick together. So when you block it, you risk stomach ulcers and bleeding.
Which led to the development of the KOX2 selective inhibitors, like celecoxib.
The idea there was to only block the inflammatory KOX2 while sparing the protective KOX1. It's a trade-off, with its own set of cardiovascular risks we won't get into today. But the main point for our discussion is multimodal analgesia.
A pain ladder.
Start with non-opioids, like NSAIDs and acetaminophen. Then, if pain persists, add a weak opioid. Then if it's still uncontrolled, a strong opioid. But you never forget the foundation. You treat the patient, not just the receptor.
So putting it all together, a patient comes in with a broken leg after surgery. You don't just blast them with fentanyl and walk away.
No, that's terrible medicine. You might use an opioid for the severe, immediate postoperative pain, but you'll also have them on a scheduled NSAID to reduce the inflammation at the break site. You'll use acetaminophen for a baseline level of analgesia. And you have a plan to get them off the opioids as the acute injury heals before that differential tolerance trap snaps shut.
It's a balancing act. It requires constant reassessment.
It is navigating a razor's edge every single day with every single patient.
Which brings us to our outro. We've traveled from the poppy fields to the G-protein receptor, to the rigid chest wall, to the paralyzed gut, and finally to the multimodal strategy.
We've seen that these drugs are not magic. They are molecular machines. They lock calcium channels. They open potassium channels. They hack the brain's reward system and its descending pain control pathways.
And the title of our episode included Responsibility.
That is the final thought I want to leave with you. As clinicians, we have the power to turn off suffering. That is a godlike power, and it's an incredible gift to our patients.
But the biological cost is high.
It's incredibly high. We turn off the drive to breathe. We paralyze the gut. We risk hijacking the reward system in a way that can destroy a person's life.
So the clinician's job isn't just pain relief, it's much more complex.
No. The clinician's job is to respect the complexity of the pain system and the power of these molecules, to understand that relief is not the same as cure, and to ensure that in our attempt to silence the pain, we don't silence the patient permanently.
A sobering but essential thought to end on.
Indeed.
To our listeners, this was a conceptual map. Your mission now is to go back to the source. Read Goodman and Gilman Chapter 20 for those molecular patterns. Read Ketsung Chapters 31 and 36 for the clinical protocols and the drug specifics.
The map is not the territory. Reading is essential.
Thanks for diving deep with us. We'll see you on the next one.
Stay curious.